Okay, so we're going to pick it back up for part 2 of this lecture on neuroendocrine tumors of the GI tract. So now we've talked about all the background, and we can get into the actual surgical management of these tumors, and we'll go by primary site. So the most common type of GI neuroendocrine tumor is an appendiceal tumor, so we'll talk about those first. These are often found incidentally after an appendectomy. That's typically the test vignette that you're going to get. And basically they're going to give you a size of a tumor and a location. They may give you some pathologic features as well, and then you have to make a decision. Are you going to just go with the appendectomy that's already been done, or are you going to have to go back and do a right hemicolectomy? The main purpose of doing a right hemicolectomy is to harvest lymph nodes. So bottom line, less than 2 centimeters and a favorable pathology report. Margin negative appendectomy is all you need. Again, if they have not had a CT scan, which most of the time these patients will have had a CT scan, but if they never got a CT scan, they should get at least one CT scan to make sure there's no obvious nodal disease. Okay, so if they have a tumor that's greater than 2 centimeters or less than favorable pathology report, then they need a right hemicolectomy. Now, how are we going to define less than favorable? It's going to be positive margins, evidence of positive nodes, mesoappendiceal invasion greater than 3 millimeters, subserosal invasion greater than 3 millimeters, intermediate or high grade, or angioinvasion. So all these things listed here are basically just things that put you at high risk for nodal disease. These neuroendocrine tumors of the small bowel and appendix, they go to the nodes early. So even a very small primary tumor can go to the lymph nodes. So you really have to have a high suspicion and go do a nodal harvest if any of these things are found on the pathology report. So the take home, up to 2 centimeters in favorable path. All you need is a margin negative appendectomy. Everybody else needs a right hemicolectomy. And again, we talked about those things that are considered not favorable on the pathology report. One quick word on appendiceal goblet cell tumors. They like to ask this on tests. So this used to be thought that it was a variant of neuroendocrine tumors, but really what it is a mixed tumor with some neuroendocrine elements and some adenocarcinoma. It's graded by the adenocarcinoma component, and it's usually a high-grade tumor. These tend to be fairly aggressive. So you treat them as an adenocarcinoma, and you do a right hemicolectomy for all of these tumors. So any appendiceal goblet cell tumor of any size or any variety gets a right hemicolectomy. And then if they have node positive disease, they get chemotherapy that's used for colon cancer, aka FOLFOX. So goblet cell tumors are not neuroendocrine tumors. You get a right hemicolectomy, you get FOLFOX for lymph node positive disease. Small bowel neuroendocrine tumors, the key thing here is that the nodes are bigger than the primary. So you can have a very small primary and yet have a lot of nodal burden. So take a large nodal sample anytime you go to resect these. Think nodes first, primary second. And this is just kind of the weird little paradigm of these. Normally you think big primary tumor, small nodes. For small bowel neuroendocrine tumors, think small tumor, big nodes. So their nodal burden, their nodal tumors will actually often be bigger than their primary tumors. So when you go to do a resection, you want to go way back on the mesentery, start back here, take the vessels as they come off the SMV or SMA, SMV, and then take all the distribution that's covered by those vessels. So you want to take a wide nodal harvest, and the nodal burden again is often dramatically more than you would think from these very small primary tumors. So the other big thing on these is that they're often multifocal, at least 20%, but you need to run the entire small bowel and look for second primary. So it's very common to find one of these tumors and then find another one somewhere else in the small bowel. And again, a lot of times you go in, all you can see on the CT scan is this big lymph node in the mesentery, and then you go out, you find one primary, you run the small bowel, you find a second primary somewhere else in the small bowel, and you find more nodes downstream. So it's very important to run the entirety of the small bowel. As a result, some people talk about doing these resections minimally invasive. Personally, I would advocate for a mini laparotomy on all of these patients so that you can run the small bowel with your fingers, because again, sometimes these tumors are very small, 1 centimeter or so, and you can't necessarily feel that with a laparoscopic instrument, and you can't see it with robotic running of the small bowel. So it's very important to run the small bowel with your fingers, which I would say always requires a mini laparotomy. And then the other thing to know is that these patients often get in trouble not from their primary tumor recurring, but from their nodal disease burden. So we showed that CT scan earlier with the big tumor with all the desmoplastic response around it, kind of sucking the mesentery into the tumor. And that's often what hurts these patients in the long run, is that these big nodes in the mesentery sort of suck the mesentery in, and they get small bowel obstructions from that. And their nodal burden may be so deep into the mesentery, very near the root of the mesentery, that you can't actually resect it. They're very bloody tumors that come right off the SMA, things like that. Very hard to resect in those cases. And that can be ultimately what kills these patients, is just the desmoplastic response of their nodal burden. So again, this is that CT scan showing all this desmoplastic response and kind of the mesentery shrinking down into that tumor. And you can imagine when this gets pretty dramatic, you could have a small bowel obstruction from the mesentery getting so foreshortened. So patients with metastatic disease and obstruction may need a palliative resection of their nodes, or even a bypass of the small bowel around that area. And this should be done if the patients have symptoms, even if not curative, because again, these well-differentiated tumors in particular have a very indolent course, and these patients will live for a very, very long time. And so doing a palliative resection is a reasonable option on these patients because they'll live for a long enough time to make it worthwhile. And so if you have a patient with nodes that you can't resect, but one big node that's causing a problem, it's very reasonable to go in and take the nodes out that are causing a problem so that they can eat and live their life again. So again, small bowel neuroendocrine tumors, the key are run the bowel because they're often multifocal. Nodes are very important, and often the nodes are bigger than the primary tumor. So colorectal nets, I'm going to start going a little faster here because these are very rare. So who doesn't need further surgery? Basically, a small tumor less than 1 centimeter that's margin negative and low grade from an endoscopic resection, you can just stop. They don't actually even need further follow-up as long as their margins are negative and they don't have any evidence of lymph node disease. Basically, everyone else gets a formal resection for the colon. And then when you start talking about rectal nets, the problem is that a formal resection is a TME, which is a big operation, a total mesorectal excision. So you think a little bit more about it. So basically less than 2 centimeters, no muscularis invasion. Try to do a transanal or endoscopic resection. More than 2 centimeters, muscularis invaded or positive nodes on MRI. Then you're going to treat like a rectal cancer and do a formal TME, so an LAR or an APR. Take-home points here are, especially for rectal nets, we have to think about it a little bit more because rectal surgery is a bigger deal. Small, low-grade node negative, try to do an endoscopic resection greater than 2 centimeters, just like the appendix, into the muscularis or nodes on MRI. These patients need a TME. So that 2 centimeter number is very important for these GI neuroendocrine tumors. And then duodenal nets, nobody really knows what to do with these. You try to do a local resection if you can, endoscopic or transduodenal, so you can open the duodenum and just kind of scoop these things out. You have to think about the risks and benefits for a Whipple, especially if, you have to think about the risks and benefits for a Whipple, especially with a well-differentiated neuroendocrine tumor that is pretty low risk for having nodal burden. Are you really going to do a Whipple on that patient? Again, if they're over 2 centimeters or they're invading deep, intermediate grade, or you see nodal disease on a dotatate or something like that, then you probably need to do a Whipple. But bottom line is the reason you're doing a Whipple is mainly to get a reasonable nodal sample. So if you feel like they're low risk for nodal disease, then just try to do a local resection. But if they're high risk for nodal disease, then you got to do a Whipple. So metastatic disease, this is a common saying among surgical oncologists, biology is king. So these well-differentiated neuroendocrine tumors, indolent tumor, they're going to live a long time. So even in the setting of metastatic disease, they're going to live a very long time. Again, for a small bowel or a appendiceal tumor, they may live 10 years with their metastatic disease. So don't hasten their demise with surgery. Don't do a surgery that has a 10% mortality on a patient who can live 10 years with metastatic disease even without resection. So you have to think about your operations. The flip side of that is that if you have one liver met and you can cut it out, then that patient might be cured. So that indolent disease can kind of work both ways, but just understand that that's the biology of these, and that's super important. If they do have a higher grade, intermediate grade, high grade neuroendocrine tumor with a Ki67 in the teens or something like that, then understand that those are a little bit different beasts. They're going to come back quicker. You have to think a little bit more before you go to the operating room. Some people would even advocate for doing a somatostatin analog for 6 months or so pre-op to make sure that they don't met out before you go do a big operation on them. Debulking for symptomatic disease is generally advocated if it can help. So again, even if they have metastatic disease, you can't get it all, and you can't get it all out. If you can cut 80 to 90% of the disease out and they're symptomatic from it, meaning like a carcinoid syndrome or something like that, there are definitely people who advocate for doing those surgeries, even if it's an R2 resection, as long as you can get 80 to 90% of it out. Also, if they have nodal disease that's causing obstructive symptoms and you can fix that problem, even if you can't cut all the tumors out, go ahead and take them to the operating room and do a palliative resection. Finally, liver-directed therapy for patients who have symptoms from their liver tumors, have pain from their liver tumors, or those with carcinoid syndrome, doing surgical resection of their liver disease does seem to help. It does seem to work better than liver-directed therapy. But that being said, if you can't do a resection, liver-directed therapy also seems to help. Things like TACE and Y90 seem to help as well. And then finally, medical management for neuroendocrine tumors that can't be resected. I don't want to go too crazy here. Again, I'm going to say biology is king. Somatostatin analogs are the mainstay of this, so you can give octreotide, which sort of gives an off signal to the somatostatin receptor and keeps these tumors from proliferating. There's two big drugs, octreotide LAR, which is a long-acting octreotide, and then lanreotide, which is just another variety. They have both been studied in large phase 3 trials and shown to improve progression-free survival. Octreotide is a little bit cheaper than lanreotide. There's probably no big difference in efficacy between the two. So octreotide is the mainstay of therapy for these. And then everolimus, which is a TKI, has been studied in a phase 3 trial. That's an option. And then sunitinib is an option. I would just kind of know those are options. I don't want to go into it too much. But all these drugs have been shown to improve progression-free survival, but there's minimal impact on overall survival because all these trials allowed for crossover when patients progressed. So bottom line is you don't need to start these therapies right away. There's no role for adjuvant therapy after resection. So if you resect someone who's high risk for recurrence, you don't put them on somatostatin analogs. You just wait until they recur and then put them on it. There's no difference in long-term overall survival whether you start it right away or wait until they progress or recur. You can just treat them once they develop progression or symptoms. And then the final thing I want to touch on is the new kind of fancy treatment for these, which is called peptide receptor radionucleotide therapy, or PRRT. The brand name is Lutathera. This is based on the same concept as the dotatate scan. So you remember this picture from before. You had a peptide chelator and radioisotope. So now we're going to change the payload from a radioisotope that lights up on PET scan to a radiation agent. So the payload is now luteum-177, which is cytotoxic. So same thing, you link the peptide, which is octreotate, with the chelator, which is DOTA, to now luteum-177. It gets dumped into the cancer cell, and then instead of just lighting up on a PET scan, now it actually kills the cell. Lutathera is the brand name, or it's luteum-177 dotatate therapy. So this has been studied in a big phase 3 trial that was published in New England Journal of Medicine in 2017. It's called the NETTER-1 trial. These are well-differentiated tumors. Which had already progressed on octreotide. The one key thing here, I want you to know this, that these patients all had to have somatostatin receptor scintigraphy score, meaning basically octreoscan or dotatate scores of grade 4, which means they lit up a lot, or grade 3, which means they also lit up a lot. So basically almost all these tumors lit up on either octreoscan or dotatate. So you know they have somatostatin receptors. And then you give them this drug, and their 20-month progression-free survival was 65% versus 11% for octreotide alone. So the bottom line is this drug seems to work in patients who light up on dotatate, which makes sense. So as far as which medical therapy to choose, there's a bunch. Nobody really knows. Bottom line is NCCN guidelines reads, currently there are no data to support a specific sequence of regional versus systemic therapy and no data to guide sequencing of the systemic therapy options. So it doesn't really matter. Nobody really knows is the bottom line, but most people start with octreotide as it's the cheapest and seems to be pretty effective. All right, so I'm going to try to sum all this up on one slide here. So we need to know these are enterochromaffin cells or EC cells. We know that there's going to be chromogranin as a blood test, and then urinary 5-HAAA. Those are the tests that can sometimes demonstrate that you have a neuroendocrine tumor. Most common sites, number 1 is the appendix, number 2 is small bowel. Prognosis is very good, especially for the midgut tumors. So small bowel appendiceal and cecal tumors have extremely long overall survival, and these patients do very well. Carcinoid syndrome, remember flushing and diarrhea, also bronchospasm, and then heart disease, TIPS, tricuspid insufficiency, pulmonic stenosis. Poorly differentiated neuroendocrine carcinoma is not a neuroendocrine tumor. It's very different and treated differently. Grade based on Ki67 and mitoses. Remember 2 and 20, less than 2 is low, 2 to 20 is intermediate, over 20 is high. Imaging, we're going to get CTs. The tumor is going to light up on arterial phase. The lymph nodes are large with a lot of desmoplasia. They can also have calcifications around them. Dotatate is the new imaging, which uses somatostatin receptors and PET technology to light up these tumors. Again, PET scan for dotatate, SPECT for octreoscan. That's why dotatate is better. Surgery by site, appendix, less than 2 centimeters and favorable, just needs an appendectomy. More than 2 centimeters or bad pathology, needs a right hemicolectomy. Small bowel, we have to worry about multifocal disease. It goes to the lymph nodes early and often. Run the small bowel, look at the nodes, and take a lot of nodes with your resection. Rectal, 2 centimeters into the muscularis or nodes, needs a TME. Metastatic disease, resect if low morbidity, debulking is okay and somewhat effective. All right, and then medical therapy, somatostatin analogs, lanreotide, octreotide, these are the most common ones, and then everolimus and sunitinib if those start to fail. And finally, PRRT and Lutathera. Again, these are very similar to how the dotatate scan works, but you have a therapeutic payload instead of just diagnostic. So that is the end of the lecture, and if you want to take a picture of this final slide, that should summarize kind of everything you need to know for the AB site and all the buzzwords and things that you should memorize.